Well, it's almost good afternoon. I'm your host, Don Burgess, here on News, News and Views, and we're here at the House Bermuda. And today's guest is the Shadow Health Minister and for seniors, Patricia Gordon-Pamplin. Welcome.
Thank you very much. Thank you, Don.
We just wanted to talk about health care and health costs. The government's unveiled a new plan that they've gone through a consultation period that's going to take 4 months or so. Just as an overview, how would you view Bermuda's health coverage and costs?
Obviously, the costs have risen exponentially. Costs are prohibitive. The coverage that we have at the moment for the care that we get, the coverage works. We pay for it. We pay through our noses. And obviously, from a perspective of trying to decrease the cost of healthcare in Bermuda, certainly from a One Bermuda Alliance perspective, we want to ensure that we can assist in any way possible to ensure that costs are maintained and decreased to any extent possible. What we want to ensure, though, is that we don't go off on a tangent of doing something that is so completely new and different that it is not tried and tested, that it causes the system to implode.
Right.
In trying to curtail costs, we don't want to end up compromising quality of healthcare. And that's the concern that I have with what I've seen the proposals. You mentioned that there was going to be a 4-month consultation period. That disturbs me. It disturbs me from the point of view that we heard the government indicate that there was going to be less copay for people when they go into doctor's offices. That's a wonderful thing to have to pay less. But how do you accomplish that? Do you accomplish less copay for the patient by saying to the doctors that you have to reduce your fees? Mm-hmm. Do you say that the insurance aspect picks up more? Or are you saying that a larger portion of a doctor's visit will go into this new Bermuda health plan that they have tried to implement? So we don't know the answers, but the minister has indicated a number of $514 of premium that people would have to pay. What I find interesting is I've had consultations with doctors, both collectively and individually, and they've said most of them do not know what it is that is being proposed. They don't know how it's going to impact them. They don't know how their services may be compromised if their fees are not going to be what they are now charging. What I find interesting is that a medical profession, notwithstanding that we all require it, it still is a private business. So we are effectively trampling on an area in which government is saying to private industry, this is what you can or cannot charge. And while that may not be a bad thing to try to keep costs from galloping out of control totally and completely, we want to make sure that the balance is there. The level of consultation that needs to be had, in my estimation, has not nearly been addressed. And for the minister to say that $514 is the amount of money that one would have to pay as a premium and that this will make it all work, it could have been done with the provision of proper actuarial studies, with proper documentation, with empirical evidence that says that this is being worked through. And I can't see that that has happened. So the doctors don't know the extent to which they are going to be impacted. So a 4-month consultation period. What I see with consultation with the government and the way they do it is that they have a predetermined idea as to what they want to do. Consultation to them says, let's call the doctors in, let's call the stakeholders in, let's have a meeting. We're going to tell you this is what we're going to do, and then we're going to do it. It's not about having an interactive and an effective communication system that's going back and forth. So I believe that 4 months is a bit ambitious in order to be able to change something that has been historically the way we have done things. Now, I'm not saying that we have to stick with a dinosaur, not at all. I'm saying that if we do measured consultations and do things and implement them in a methodical way, then I believe that we would have a far better outcome when we start looking at all of the component parts of what helps to make healthcare as expensive as it is in Bermuda.
No, I may have misspoke a bit. I said 4 months, but maybe...
No, that was 4 months was a period
okay.
of time
Okay.
when the government had indicated that they wanted to have a consultation, and they wanted to have certain things in place by 2020, and this 4-month consultation was effectively the timeline that they had given.
Yeah. But what's the bad part of at least asking people if, if doctors, physicians, the insurance companies have concern, can't they give their input and help shape what the policy is going to be like?
Oh, absolutely, and that's what should happen. But you see, what has happened effectively is if the minister can come out and say $514 is the price that you're going to pay, but now you guys, as the stakeholders, tell us if this is good, better, and different. That is putting the cart before the horse. What ought to have happened, in my estimation, is that the empirical evidence ought to have been collected, the doctors ought to have been consulted with, the statistical evidence should be there. BHEC is able to compile information, so they should be able to have all of these information to be able to take to the doctors and say, this is what the population is costing us, and this is what we think, and how does this impact on you? Not to say to doctors, or not to say to patients, you're going to have a different copay, when the doctors don't know what it is that they're meant to be doing. All of this is combined with how the government has chosen to fund the hospital, and so it's just creating confusion. And I believe that many of the things that they've articulated clearly haven't been thought through.
You talk about government funding the hospital. How do you see that's playing into this?
Well, I think that, the government had committed $300 million to funding of the hospital. $300 million is an awful lot of money. One of the things that we've not yet been able to determine from the government is how is that $300 million going to be divvied up in the provision of services by the hospital. The hospital they provide certain services. As an example, they provide MRIs. MRIs provided at the hospital will be paid for out of the $300 million that they get from the government in this block grant. If the hospital elects not to schedule somebody for an MRI, that person is sent out to the private sector to have their MRI done there. And that MRI that's being done in the private sector, notwithstanding that if a patient is willing to wait for the hospital will be responsible for paying for the cost out of the $300 million. They send that person over to the private sector. That private sector visit, it has to be paid for by the insurance out of the 20-something dollars that the insurers were able to retain out of the standard health premium that the government has now reconfigured. So it seems to me if the hospital is a provider of MRI services and is being paid out of $300 million to provide those services, the hospital should be made responsible for MRI services. It should be a service and not a provider, in my estimation. So if the hospital is getting $300 million, if they cannot provide on a timely basis an MRI and they have to send somebody out to a different provider, then the hospital should pay that provider, in my estimation. If an individual decides that they wish to go to a private provider, that's a different story. But if the hospital is saying that we cannot accommodate you, we don't have an appointment time that is sufficiently timely for your doctor to be able to get your results, then the hospital is effectively saying we cannot provide the service that we are being paid for, and therefore they should pay for that service outside of the hospital. And I don't think that that's unfair. I think that that is something that I believe that the patient should expect. The one thing we do not want is with a new healthcare system to find that our healthcare has been compromised. And at the moment, we have excellence in healthcare, and there's no reason why the government's desire to move to this single-payer system, which perhaps works in places where there's a larger population base, where there is a far higher tax base that supports a more socialized medical system. If the government wants to move to that, we are going to find that there are going to be delays. The quality of healthcare is going to be compromised, and that is my concern.
Well, just getting back to the hospital a little bit, I mean, if they're only given $300 million to operate for their budget, and let's say end of September, they're at 250 million. So they're going over per month what they should. And it looks like they're going to go over the 300 million before the end of December. I mean, it seems like to me like they would be pulling back services.
Of necessity, they will cut back services. And what's interesting is that we have seen, I think this new policy went into effect June 1, if not July 1. I believe it may have been June 1 with this block grant. And what's interesting is that we have already seen and have already had reports that services at the hospital are being compromised, that they are being cut back already. So historically, the hospital had charged, first they used to charge on a DRG, diagnostic related group basis for charging. And then they moved from that to a fee-for-service base, which is something different. And the government decided that fee-for-service wasn't working, so now they're going to go to this block grant, and the hospital will have to work within that block grant. What we have not been given, though, is the basis on which the hospital is now charging people for whatever services they are providing. So we don't know what's whittling away at the $300 million that the hospital has. So we don't know whether the hospital, and I'm not trying to cast aspersions on the hospital, and I hope that I can make myself very clear in respect of that. I'm not saying that the hospital is wrong to try to make sure that they basically cut the suit according to the cloth. What is happening, though, is that we don't know what standard is being used for their billing that determines whether a service is how a service is being billed for. So we don't know what the hospital is doing to whittle away at the 300 million. We don't know whether they've decided, well, let's take the first 50 million, let's salt that away, and let's really operate with 250. They may not, I don't know. They may find that the demands on their services is such that it's difficult for them to be able to manage with the money that they have, and they might find that they are providing as many services as they can and that the money's running out. They are obligated to stick within that budget. So if $300 million works, fine. If $300 million works, I'm sorry, Mr. and Mrs. Bermuda, you either have to wait or you just don't get seen. Right. You don't get the service.
Well, you're talking about waiting, and I guess one of the big concerns of the single payer system is like everyone gets the service, but there's a delay. So I'm familiar with, because of my relatives, Canada, where sometimes, somebody might have to wait 8 weeks to get that first chemo treatment or things. But why shouldn't that be different in Bermuda since we're smaller?
Well, it should be different because we have a standard and a sophistication within our community where we have been able to have the services that we want to have. And to say to somebody now, after being lulled into a sense of comfort that we have an excellent standard of service, to now be told, sorry, you've got to wait now for 6 or 8 weeks for something that you were able to get an appointment for within a week or two. Now you've got to wait 6 or 8 weeks, or the service is just not going to be available anymore. We can't give it to you at the hospital. Single payer systems, as I say, require two basic ingredients. One is a population size that supports it, and two is a tax base that ensures that the money flows into the system. And in the absence of that, you are going to have compromised services.
So what would be, from an OBA perspective, how would you change things in the health system then to bring down costs?
Okay, I think the first thing that we need to do is to start to look at the people. The integral parts of the health system comprise the patients who require services, the facilities that provide the services, such as the hospitals, laboratories, and the like, and the doctors and the people who are the experts in the area. First of all, get them involved. Don't come with this top-down, we're the government, we're here to help, and we're going to tell you how to do it. Get everybody involved. When we heard initially that there were some 5 to 6,000 people who were under or uninsured, and therefore the system needed to be upended to provide health care for those people. Nobody wants to deny health care for people who don't have it. Nobody wants to deny access to medical treatment. But I don't know that there is anybody, whether they are insured or not insured, who could not go to the hospital if something is wrong. So what we need to do is to say that we've got insurance companies who they are able to have the creme de la creme of patients in terms of their claims experience, because they can pick, choose, and refuse whom they can insure. And therefore, they will get premiums that they may not necessarily have to pay out on the back end. Their claims experience is better than the government system, the GEHI, the HIP, or the Future Care. So the claims experience for an insurance company of necessity is going to be greater, because it's going to be better, because they have greater discernment in terms of who they should or shouldn't insure. So the government could have very easily started out by saying to the insurance companies, we believe that there's a population of 5 to 6,000 people who are underinsured, and we are going to demand that those people be spread among the existing insurance systems to make sure that those people have coverage. And I don't think that you would particularly get pushback from the insurance companies. But these are conversations that needed to be had. These are not things where you say to the insurance company, I think you're making too much in profit, and therefore we're going to take things away we're going to undermine the operation of an insurance company, and thereby try to use that money somehow and make things balance. What would have been wrong with saying to the insurance companies, work out among, this is a population. We want this population covered. And this population is going to be covered. And you as insurers, you have a profit margin that you may be enjoying. And therefore, it's your obligation to ensure that people are covered. That way, the one thing that I don't believe that there's been sufficient appreciation for is the level of interventions that the insurance companies make with providers in terms of negotiating fees that are ultimately paid. I know for a fact, I've seen a bill on a personal level, a bill that came in for $11,000, which was billed by the provider, which ultimately, when it was paid, it was settled at $3,000 and change. The differential being the negotiation power of the insurance company to bring that $11,000 bill from the provider down to $3,000. If I had to pay it myself, it would be the $11,000 that I would have to pay. But because of the insurance coverage, they are able to negotiate a discounted rate for settlement, and the system is happy. Now, if we go to the single payer system, the question begs, who manages it? How are we going to be able to effect the same levels of discounts, deep discounts by providers that is now being enjoyed by people who have the insurance companies as the intermediary to negotiate on their behalf? I just am concerned. I don't know. The government hasn't said that they've chosen a provider or chosen an insurance company or chosen somebody to manage this new system that they wish to employ. What is the plan? Tell the public of Bermuda. Be transparent. Tell us what is it that you are hoping to do in terms of how is this new system going to be run? Is it going to be as efficient as we have now? And will people be guaranteed that they will have coverage? When people are told we'll have less copay, they go to a doctor's office. The doctor doesn't know anything about it. What does a copay do from a doctor's office perspective? A doctor's office they make claims to the insurance company, or they make claims to government. And my experience and my information coming from the medical profession is that the most horrendous system of reimbursement is through the government system. They say GEHI is one of the absolute worst reimbursement systems that they've ever experienced. And then what it seems to be is that with GEHI, my understanding, this is the complaint that's come from the medical profession, is that they will get a lump sum of money. A doctor, having submitted claims, they'll get a lump sum of money with necessarily no rhyme or reason as to how. It's like the squeakiest wheel gets the oil. Right. So if you moan and groan enough that I haven't received my settlement, I haven't received my reimbursement, then you might get a check next month. But then the guy who would have gotten the check next month doesn't get one because these guys got one. And it's like the system itself does not seem to have been able to cope with the demands on the claims. So if you're saying to a patient that, your copay will diminish, and that's great for the patient. And obviously
everyone's excited about that.
That's great for the patient. I mean, I don't want to pay a dime more than I have to. You go for a dental cleaning and you have to pay $170, which is your share. If somebody tells me I have to pay 50 and not 170, obviously I'm going to be excited about that. But the reality is, if the part of the claim that the provider is going to submit doesn't get settled, how does that provider keep his office running? I mean, these are just the realities of finance. And I'm not certain that all of this has been taken into consideration in some of the changes that have been made. As I said to the minister during the debate and earlier in the year, that some of the changes that have been coming, they've been coming piecemeal. We didn't have an overarching vision. So I think now this overarching vision that she's attempted to portray is now this new Bermuda health plan that they want to implement, which will upend some of the things that have happened.
Yeah. And part of the thing is, just to interrupt you, part of the thing is with the way the healthcare is now, there's people who are underinsured, and we can think of like the young girl who's 13, who's Unaya Bell, who's gone. She had the brain hemorrhage, and she's overseas, and the family's got a GoFundMe page to help her. I can think of another woman who's got one major medical issue, which makes her basically unhireable, because when the last company that she worked at, the health premiums for the small group of people that were part of that company kept rising because she kept having to go overseas to have operations and things. So then the company was losing other employees who didn't want to pay
the higher insurance rates. Now, see, what's interesting with that is that we had the mutual reinsurance fund, which the idea of which initially it was brought in to take care of things that were outside of the normal insurance claims. And those are things, it ended up being used for things like the dialysis treatments at the hospital and stuff. So that mutual reinsurance fund was effectively the pot of money that sat to the side that effectively said, your claims experience is not normal. There's nothing wrong with those types of situations that you've just alluded to being put in that mutual reinsurance fund type of money, type of pot, so that the insurance for the rest of the group don't rise exponentially to the point of unaffordability for the participants. And I think that is where the challenges come. We have not studied this problem sufficiently. We've come with a sledgehammer approach, which effectively says, we're going to do it this way because. But there's nothing that has been said thus far that says that this young lady to whom you've just referred is still going to be taken care of out of the $300 million that the hospital has. Is the hospital going to be responsible for the care of this young lady? They cannot provide the service. So this young lady has to be sent overseas. The hospital can't provide the service, but the hospital is getting the money for providing services. So if they can't provide the service, why is the hospital not responsible for including as part of their budget money for the services that they're getting paid for that they cannot provide? So this young lady has to go overseas. She's going to be incurring costs at a far higher rate, presumably, than what would have been incurred had she been able to be treated at the hospital. But if the hospital can't treat her and the hospital's getting all this money, I mean, take it to the extreme. What if every case that goes into the hospital was one that the hospital feels that they could not provide the service? What's our $300 million doing?
Right.
They'll collect it and they say, sorry, I can't provide this service for you. So you go over to Leahy, you go over to Columbia, you go over to Johns Hopkins, and we'll sit on the money that we're getting paid for the services, for providing services for healthcare in Bermuda. We can't provide the service. You go over there and somebody else will pay. That can't be right. That cannot be the intent. And I can't see that anything that we've done thus far has effectively said that we are going to harness the costs of healthcare. We've shifted the money, but we haven't seen the savings. So until the government is able to come and say that these are the efficiencies that we're going to be able to get. These are the reductions in costs that we've been able to look at. What about things we tried to implement pre-certification? It went over like a lead balloon.
What's pre-certification?
Pre-certification effectively says that if you have a patient who is requiring additional services in sort of high technology services that are of necessity a lot more expensive, then let's make sure that this patient really needs all of these tests. You know, Bermuda, and one of the reports that I had seen is that Bermuda has a higher degree of specialty tests that are required by providers for their patients than anywhere else in the Western Hemisphere. So what are we doing that's so different? Why are we providing 5 X-rays for somebody within a short period of time for a similar situation? Why are we providing MRIs? Why are we providing CAT scans? Why are we providing ultrasounds for the same patient 3 and 4 and 5 times over?
I have a friend who's an actuary, and he's run the analysis on that, and he said that Bermuda's, compared to the United States, Canada, or the UK,
it's way off the charts. And the question begs why. And what we have here is a situation, and I'm not faulting the owners of enterprise, and that's not what I'm intended to do. But what I'm saying is that when you spend money to buy massive, expensive equipment, that equipment, A, has to be paid for, and B, has to produce a profit for the investment and for the investors. So as a result, the only way you're going to be able to have any return on that is to see utilization going up. So is the utilization called for as far as the patient is concerned? That is the question, because if I owned some kind of diagnostic equipment that I've invested in, I've got to pay for it, I want to see my profit margin, and I own it as part of my organization, am I not likely to say, I'm going to send Tony and Joe and Susie and Annie and send everybody to have this service provided? Are those services necessary? And that's where pre-certification would come in. Is there a clinical necessity? And these are things that are not going to be determined by somebody like me who has no medical background or experience. And I tell people, perhaps my father was a medical doctor, maybe by osmosis something may have sunk in, but that doesn't qualify me. So these are things, pre-cert would be able to look at things, would be utilizing people who are expert in that area. And it doesn't necessarily have to create an inordinate delay for the patient, because that's the advantage of technology. Things like this can be looked at and determined in a matter of an hour. And so you've got a quick turnaround time when you've got that liaison. And these are things that work in other jurisdictions. Now, in other jurisdictions, it is illegal for a healthcare provider to also have laboratories attached to their, to have pharmacies attached. You can't do it. So there is no tendency, because it's not legal, there's no tendency for providers to overutilize services with a profit margin and with a profit motive. And I'm not saying that that's the only motive, and I'm not suggesting for a second that every doctor who has a laboratory, who is referring their patients, the self-referrals as we call them, I'm not saying that every one of them is, that there's some cynical and there's some some difficult circumstance, that there's something that is untoward. I'm not suggesting that, but I'm saying that if these things are controlled, then you can start to see a real impact on not just utilization, but if utilization is managed to the point of absolute necessity, then that utilization, or that the extra utilization starts to decrease, and therefore the cost of healthcare overall will decrease.
Well, part of the thing, I'm just looking at it from a patient standpoint and being a little bit lazy or like the convenience. I don't mind going to the doctor and then using their lab, because then I'm only going to one
It's
place.
right there.
Right.
And that's quite possible, and there's nothing to say that a lab couldn't be right next door. So it's not a matter of lack of convenience. There's nothing to say that you couldn't have a lab that's in the same general vicinity of a doctor's office. But for a provider to own that facility, it's not something that's allowed in a United States context.
We haven't talked about future care and the whole scheme of things, and future care is not included as part of the new health plan. But what do you see as some needed maybe tweaks to future care?
Okay, future care started out being an idea that was perhaps well intentioned, but ended up not being quite what it was intended to do. What happened initially was that there was a group of people who were age 65 who were able to be put on future care 1 year. The next year, they said, okay, now we'll take a group of people who were 70 and over and we'll bring them into future care. And then, but their rate was going to be different than the rate of the people who came on the first time. And then when they started to include those people who were in the middle, this was all under the former PLP administration, when they started to include the people who were in the middle between 65 and 70, the rates were all over the place. So you ended up with the same services being provided to 3 different demographics of individuals who were all paying different prices for the same service. And somehow, to me, as an accountant, it just didn't seem to make sense. So the first thing that I did, I actually served as health minister. One of the first things that I did was to implement a system whereby the premium for future care was standardized across the board. Now, some people were paying less because they were the first ones who got in on the scheme, as it were, and some people who came in later were paying more. So the money that, or the actuarial extrapolations that were done, the calculations that were done, gave a range of premium that we were able to look at and be comfortable with, that the system could support. And that leveling off made the people who were at the lower end have to pay a little bit more, and the people who were at the upper end pay a little bit less. But the fee was the fee, and everybody who was on future care was paying the same premium. And I think that that hasn't changed under this new administration, which means that they obviously agreed with what we had done there. Now, we obviously got credit by people who were paying more in their premium, and now that premium had been reduced, and we were said, oh, you all are wonderful. And those people who were paying less and now had to pay a little bit more, we were everything but a child of God. So, but we understand that. But in order for the system to sustain itself, it was quite important for us to at least be fair to the people who were utilizing those particular services. Right. So that's what we did with future care. Now, in terms of the benefits of future care, obviously there are restrictions, but we want to ensure that people have the benefit of prescription coverage that is appropriate to them. What happens is you might have a husband and a wife, both of whom are on future care because they're at that senior age, and one uses all of their prescription money before the year is up. The other one is perhaps in a better state of health and doesn't have to use quite as much. So is there some way that we can start to look at equalizing, even over families, the allocation of money for prescription benefits, as an example? Can we ensure that our seniors have the level of care and the numbers of visits, physician visits, that are appropriate to their medical circumstances? So we just want to make sure that whatever system is employed, that people are not going to be left out in the cold, that they are not finding themselves unable to afford prescriptions, that they are not able to, that they don't find themselves unable to go to a doctor's visit because they've had their 4 visits and they've run out for the cost, over the course of the year. So we want to make sure that people are covered, but we want to make sure that whatever is done, that it is done in an equitable kind of way. And so our seniors, they're very dear to my heart. And I know that not only are seniors having to deal with whether their insurance premiums are enough to cover, whether their future care coverage gives them what they want, they're also dealing with all these extra taxes that we've seen the government implement over the course of, especially this last little while. It has been horrendous. My phone has been ringing off the hook for people who have just received their land tax bills, where their land tax has just risen so much higher than they even dreamt possible. Somebody who told me they paid $62 last time is now having to pay $150. These are seniors who are on fixed income, some of them, and they've got to pay these outrageous, exorbitant prices because we haven't been able to manage. So if we haven't been able to manage the overall country budget, how are we going to then say that we're going to upend healthcare and change the entire system and we're going to manage that well? Right. If you can't manage the things that are standardized, how are you going to manage? You know, from a health perspective, they employed a sugar tax, which has cost not just the cost of groceries to go up, but the minister and the department believes that the implementation of a sugar tax is going to help to ameliorate some of the health challenges, the diabetes, and some of the catastrophic challenges that we have. But if that sugar tax money isn't being earmarked for either educational purposes or for treatment purposes, what is there that says that sugar tax has done anything other than to raise the cost of living? Because there's nothing that gives me that comfort. And there's nothing that I can say to a senior who calls me, I'm sorry, you know, the cost of living has gone up. Your groceries cost more because the government put up the foreign currency purchase tax, so therefore the grocery stores have to pay more money to import everything that they have to import, and they have to pass the costs on to you. Your land tax has gone up. The money has to go into the pot. And now on top of that, you want to compound what you are now asking our people to pay in additional taxes, and then you want to say, you know, we're going to figure out, we know what we're doing as far as healthcare is concerned. I'm not convinced.
Yeah. Well, you know, a half hour has flown by, actually more than a half hour. Is there any one last statement that you want to leave with our viewers?
I guess the last statement that I want to leave is that we have to recognize as a people that we get the government that we vote for, and that's the government that we deserve. If we are satisfied that the costs that are being charged to us as a people are appropriate, then continue along the vein. If you are not happy with what you are being tasked to pay additionally from what you might have been paying before, if you are not happy with the idea that the Premier can make a decision to pay a backbencher additional money out of the public funds because he wants to make this person a temporary minister when he has a full complement of ministers who can stand in the gap when a minister is absent. If that is the government that you want, then that's the system that you will continue to support. Otherwise, I would suggest that you start to examine what it is that you are being asked to do as a people and how important it is for you to make decisions that are based on what's best for the country and not just the emotion of a vote.
All right, thank you.
My pleasure.
If you want to take a look at what government's proposing for the health plan, you can go to www.gov.bm/health plan, all one word. There's plenty of documents there for you to look at, and I encourage you to do so because it affects all of us. Thank you again for being our guest today, Patricia Gordon-Pamplin.
It's absolutely my pleasure.
Okay.
Thank you, Don.
All right. And thank you for joining us here at the House Bermuda on News and Views. And as always, I hope you have a beautiful day.